Now, Eric, assuming your patient is taking his medicine and doing quite well for an extended period of time and raises the question to you, do I still need to take it? When do you decide to recommend that someone might consider discontinuing treatment? I think we all ultimately put the decision in the hands of the patient or the parents, or both, actually, if the kid's old enough to think a little bit. But when do you make that, and how do you make that decision?
So there are so many scenarios. So there are some cases where we have a history and an electroencephalogram that tells you this is likely to be active until adolescence, like Rolandic epilepsy. This may be active for a shorter period of time, like occipital epilepsy. But the presence of the electrical abnormality in the EEG tells you it's still present. So when it's active and it's being treated and controlled, as long as it's present, makes sense to continue. There are some situations where we have a structural problem on the brain that is not going to go away. That scar is there unless we remove it surgically. But if the person is seizure-free, potentially that can be a lifetime treatment. So what you don't want to have is something that you tolerate short-term, but can make you osteoporotic or have other problems long-term. We may have epilepsies that have adolescent onset, and they're connected with the EEG to tell you they're still active and rarely outgrown. So in those cases, again, unlikely. So the case comes more for the kid that have a no known etiology in 2 or 3 seizures, and we decided to treat them. And in many cases, we have patients that become controlled for 2 years, and when you stop treatment, they don't require treatment anymore. And for us, again, the advantage is that they're kids that don't drive. So it's very easy to remove the treatment and see if they still need the medication with some kind of precaution. So I think with my older population, when they're driving, makes it a little bit harder. And I know probably Kate can attest to that, that sometimes putting your driving on hold is not possible.
So Kate, let's say a 40-year-old comes to you who has had 7 or 8 seizures over the course of 5 years in her 20s. Her MRI was normal, her EEG was normal. They were focal impaired awareness seizures, what we used to call complex partial seizures. They happened between age 20 and 25. And she's now 40. She's been taking a single medication, say lamotrigine at a medium dose, say 400 milligrams per day. And her last seizure was 14 years ago, for example. Is this someone that you would, how do you help decide to discontinue or not?
There are a lot of features that I would take into account in that situation. This woman is 40, I assume, maybe incorrectly, but she's probably past her childbearing planned years at least. That plays a role. So if it was a 30-year-old woman who's getting ready to plan a family, there's a bigger advantage there to coming off medication. If she's not having any side effects or having side effects, that would play a role. I assume she's been tolerating it fairly well because she's been on it for quite some time. And then, as Eric pointed out, the driving is so key here. And what ends up happening in most of these instances is that we'll talk to the patients in depth about whether to come off the medications, the risks of doing so, benefits, risks. And when driving comes up, and my typical recommendation is to not drive for a minimum of 3 months after stopping a seizure medication, that is a non-starter for most patients.
So by telling them they can't drive, you've made the decision for them. I must say my own practice is quite different. I don't tell them that they can't drive. Because in my view, if we're willing to contemplate stopping the medication, they should be willing to drive. I may say, now what I do is I will typically tell them to drive less. You know, if you're with another driver who can drive a vehicle, let that person drive. Avoid high-speed driving for several months, because again, the timing is very arbitrary. It also depends how much time they spend driving. If it's someone who is in the car for an hour or so a week, you know, the odds of an accident are very small. If the person is in the car for a few hours every day driving, the odds are very high, and that's going to make a difference.
Yeah. If they're
there's a-
driving their children around, there's
driving
a
them.
lot of factors. I think I tend to be, at least in at University of Pennsylvania, I'm the strictest on driving. And that perhaps just reflects on my own demographics and concern about other people's children in cars and my own children in my car. And I think that the driving, probably the way I do, I know the way that I represent this to patients influences whether they want to come off. But honestly, to the earlier point, our newer medications are very safe in the long term. And if the patient's tolerating the medication, I don't really know if I would personally, if I was making the decision, come off.
Yeah, I think I'm with you there. There's a very nice prediction tool that's available on the web. It was developed by Herm Lamberink in the Netherlands. And if you just do a search in your favorite engine, and most of our favorite engines begin at G if we're like most Americans, under Epilepsy Prediction Tool, it's actually, you can put it on your phone so it's right in your home screen, and you put in a few key information: age, number of seizures, whether the EEG is normal or abnormal, family history, and a few other things, MRI normal or not. And it will actually very quickly, and time since last seizure, it will very quickly give you an estimate of the probability of relapse within 2 years or 5 years. And it's available for people who have not had surgery. There's a separate prediction tool for people after surgery. And the number that the tool gives is actually strikingly high. So that 15-year seizure-free history in that woman, with everything being normal, she still probably has a 12 to 15% chance of having a relapse, which sounds awfully high to me, a 15% chance. Now that's a 15% chance over 2 years. And how long does a seizure last? A seizure lasts a few minutes. So again, what percentage in any 1 minute, what are the odds of having that seizure? Incredibly small, which is why I'm generally willing to let people drive, with still the cautions of don't drive fast, because you're much more likely to die at 60 miles an hour than at 30 miles an hour. But it's a very interesting thing, and when I put it up on my phone, show it to the patients, who invariably look at it, and nobody wants to go off medicine when they see that number.
Sure.
It's remarkable, but it's a very nice thing.